All right, let's skip the fluff and drop right into the emergency department. Your pager is buzzing, and you absolutely need a rapid-fire mindset for tackling acute cardiovascular presentations. In this explainer, we're focusing entirely on the high-yield cardiology and vascular decision logic you've got to master for test day and the wards. So let's dive right in.
Okay, picture this. I'm your senior resident, and I'm challenging you on your third-year rotation. Bed 1 has severely elevated blood pressure. Bed 2 has a fever and a new murmur. Bed 3, they're experiencing this intense, tearing chest pain. You don't have time to second-guess. What is your immediate next move to triage these 3 critical, life-threatening scenarios? Let's break down the exact logic you need to apply to each one.
Starting with our first patient in Bed 1, severe hypertension. Look, the defining difference between urgency and emergency isn't just about the blood pressure number hitting 180 over 120. It's really about the presence of acute end organ damage. If your patient has papilledema, encephalopathy, acute coronary syndrome, acute kidney injury, or flash pulmonary edema, you are looking at a hypertensive emergency. And that clinical distinction, it completely dictates your treatment. Emergencies get controlled IV drugs right away, whereas urgencies are managed way more gradually with oral medications.
Now, what if the hypertension is totally resistant to a 3-drug regimen, or it presents incredibly abruptly? Well, you need to hunt for secondary causes. Spotting physical exam and lab clues should instantly pivot your diagnosis. Here in abdominal brute, think renovascular disease. Spontaneous hypokalemia, primary hyperaldosteronism. And if you detect upper extremity hypertension combined with a brachiopulmonary pulse delay, you absolutely must suspect coarctation of the aorta. And as a quick aside, remember that in an infant presenting with shock and weak femoral pulses, severe coarctation requires immediate prostaglandin E1. Spotting these specific clues saves you from chasing the wrong treatment pathway.
All right, let's move over to our second patient from the triage board. They present with a fever, a new murmur, and on the ECG, you suddenly discover a new heart block. So, what's the diagnosis here? The absolutely crucial point is that a new conduction abnormality in the setting of infective endocarditis strongly suggests a perivalvular abscess has formed and is actually extending into the adjacent cardiac conduction tissues.
To definitively lock in that infective endocarditis diagnosis, we rely on the modified Duke criteria. It's like a giant puzzle where you mix and match the pieces. You need either 2 major criteria, 1 major plus 3 minor, or 5 minor. The major criteria are pretty straight to the point. Blood cultures coming back positive for typical microorganisms, or an echo showing an actual vegetation. The minor criteria involve predisposing factors, things like IV drug use, fever, embolic phenomena like petechia, splinter hemorrhages, and Janeway lesions, or immunologic signs like Osler nodes and glomerulonephritis.
Speaking of typical microorganisms, board examiners absolutely love to test your ability to rapid-fire associate the bacteria with the patient's recent history. Staph aureus, that's your primary suspect for acute disease, IV drug users, and prosthetic valves. Viridin streptococci should immediately make you think of recent dental work or gingival manipulation. Enterococci usually point to a nosocomial UTI, and if you see Streptococcus galolyticus, you absolutely must screen that patient for colon carcinoma. No exceptions. Now, before you do anything else for this patient, there is an absolute rule you cannot break. You must always draw your blood cultures before starting IV antibiotics. You need multiple cultures to confirm the bug. And let me explicitly warn you against using oral antibiotics for initial therapy in infective endocarditis. You need potent, targeted IV therapy, preferably IV aqueous penicillin G or ceftriaxone for susceptible strains.
But sometimes medical management just fails. There are exact conditions where you need to pick up the phone and call cardiothoracic surgery. If the patient develops acute heart failure from valve regurgitation, if the infection extends into an abscess causing a heart block, if you're dealing with a really difficult to eradicate fungal infection, or if they have massive vegetations throwing persistent septic emboli, well, antibiotics just aren't going to cut it. Surgery is indicated.
Let's shift gears slightly to a related valvular threat. Burn the image of erythema marginatum into your memory. It's a classic rash and a defining feature of acute rheumatic fever, which typically strikes kids aged 5 to 15 following untreated group A streptococcal pharyngitis.
To instantly recognize acute rheumatic fever, we use the JONES major criteria. J is for joints, specifically a migratory arthritis. O, which is kind of shaped like a heart, is for carditis. N stands for subcutaneous nodules. E is for the erythema marginatum we just talked about.
And S is for Sydenham-Correa. You need 2 major criteria, or 1 major and 2 minor, to make the diagnosis.
So why does this childhood illness matter so much in our adult cardiology explainer? It's all because of the late sequelae. The acute inflammation heals with fibrous scarring, and that most commonly hits the mitral valve. This leads directly to rheumatic mitral stenosis. On the wards, you'll hear the classic opening snap and mid-diastolic rumble. This stenosis causes left atrial enlargement, which completely sets up the adult patient for arrhythmias like atrial fibrillation, as well as dyspnea, orthopnea, and even hemoptysis.
Okay, let's pivot to preventative cardiology for a minute, specifically lipids. Here are the exact thresholds for when to pull the trigger on statin therapy. Step 1. Check that ASCVD risk. If it's over 20%, or if their LDL is strictly over 190, they need a high-intensity statin. Step 2. Evaluate comorbidities. Any diabetic patient over the age of 40 automatically qualifies for a high-intensity statin to prevent vascular disease.
But what if the issue is triglycerides rather than just LDL? Well, for levels between 150 and 500 milligrams per deciliter, we start with simple lifestyle modifications. We're talking weight loss, strict glycemic control, moderate alcohol intake, and exercise. If they already have known cardiovascular disease, we'll go ahead and add statin therapy. But pay attention to what happens when those numbers spike aggressively. When triglycerides cross the 1,000 mark, you are no longer just thinking about long-term heart disease. You are actively trying to prevent an acute pancreatic emergency. Your initial goal completely shifts to pancreatitis prevention, and your weapon of choice is fibrate therapy, along with omega-3s and absolute abstinence from alcohol.
All right, grab your trauma shears. We're heading to the trauma bay for a third patient. High-speed deceleration accident. The patient is anxious, tachycardic, and hypertensive. You shoot a chest x-ray, and bam, you see a widened mediastinum. So what are you looking for here? You're looking for a catastrophic failure of the aorta.
It is absolutely vital to contrast these 2 major aortic emergencies. Blunt aortic trauma is caused by massive shearing forces from rapid deceleration, like a high-speed car crash or a fall from over 10 feet. On the flip side, an acute aortic dissection is usually spontaneous, driven by chronic hypertension or a connective tissue disease like Marfan syndrome. A dissection presents with that abrupt, tearing chest or back pain, and you'll often find a massive pulse deficit or a variation in systolic blood pressure between the arms of more than 20 millimeters of mercury.
Let's talk about the imaging sequence, because your next step is dictated entirely by hemodynamics. Step 1 is your initial screen, the chest x-ray, to spot that widened mediastinum. But to confirm, you literally have a fork in the road. Actually, let's look at it this way. If the patient is unstable, crashing, or has severe renal dysfunction, step 2 is a bedside transesophageal echocardiogram, or TEE. It's fast and non-invasive. But if the patient is stable, step 3, CT angiography, is the absolute best test to map the extent of the damage.
Once you have the imaging, you must classify the dissection to figure out the treatment plan, and the distinction here is absolute. Stanford Type A involves the ascending aorta. This is an immediate, drop-everything emergency surgical repair. Stanford Type B is confined to the descending aorta. For Type B, you admit them for strict blood pressure control, usually with IV beta blockers like esmolol, and continuous monitoring. Simply put, location dictates the blade.
Now, if you don't catch a Type A dissection fast enough, that flap extends. If it hits the carotid, you get a stroke or Horner syndrome. Speaking of carotids, keep in mind that a spontaneous carotid dissection after neck trauma or exertion also causes Horner's and transient vision loss. Meanwhile, chronic carotid stenosis requires an endarterectomy based on severity. Down in the aorta, if a dissection ruptures into the pericardial sac, you get cardiac tamponade. And don't forget other chronic vascular threats we see. AAA requires repair based on size or expansion, and aortoiliac occlusion, known as Leriche syndrome, causes buttock claudication, leg atrophy, and impotence.
And how do you recognize that tamponade complication we just mentioned? If you're looking at an ECG and you see alternating amplitudes of the QRS complexes, you found it. This is called electrical alternance, and it's caused by the heart literally swinging back and forth in a massive pool of blood inside the pericardial sac. If your dissection patient suddenly develops electrical alternance, hypotension, and jugular venous distension, it is the undeniable signature of cardiac tamponade. Okay, let's do a rapid-fire mental checklist to summarize these algorithms. 1. Severe BP. Check for end organ damage to separate urgency from emergency. 2. Fever and murmur. Run the Duke criteria. Get cultures first, then start IV antibiotics. 3. Dyslipidemia. Use ASCVD risk for statins, but switch to fibrates if triglycerides pass 1,000 to save the pancreas.
4. Tearing chest pain. Screen with CXR, then let hemodynamics dictate CT scan versus bedside TEE.
I want to leave you with one final, high-stakes clinical scenario to test your logic. Your patient comes in after a high-speed collision. You spot the widened mediastinum on the chest X-ray, but right as you see it, the patient's blood pressure starts crashing. Do you risk rolling them down the hall to the CT scanner? Or do you call for the bedside TEE? Rely on the logic we just built. Think about it, and we'll see you in the next explainer.